I'm gonna go ahead. Hi, my name's Kaylee. I know most of you in here. It's been nice to be back. I'm gonna start by introducing Leah, and then I'm gonna let her kick everything off. So Leah has been serving the Tyler community as a dedicated physical therapist for the past 18 years. A proud graduate of UT Tyler and Texas Women's University, Leah has worked across a variety of medical settings, but discovered her true passion in vestibular therapy. She now serves as the managing therapist at Physical Therapy and Balance Center, located at the ENT Associates in Tyler. Her expertise and commitment to helping patients regain balance and confidence makes her a valuable voice in the field, and we are very excited to hear her presentation today. So thank you, Leah. Thank you, everyone on Zoom.
Are you gonna sing and dance?
Maybe, I might, depends what y'all want me to do.
I wanna watch you drink all 40 ounces.
You know, it's already done here. I've been drinking on it all day long.
She will be dancing.
You're running out of here. So my name is Leah Woodruff. I'm a PT, for 18 years, lots of different variety from hospital, home health, nursing homes. But I love vestibular, and it's a part of neuro. So we also treat strokes, Parkinson's, MS, ALS, things like that, brain injuries. But most of what I do is vestibular, inner ear, and there's a lot to that. But not enough people know about it, including doctors, know very little about the inner ear. So, you know, if you go to your normal primary care and they're like, I'm dizzy, they're gonna probably just tell you, well, it's just your medication, sorry, you gotta be on it all. But from my experience, not very much medication really makes you dizzy. There's other things going on that most doctors are really unaware of. So I love educating population. I wish I could educate doctors. I've gotten to a couple of them. But there's really a lot more education needs to know about dizziness and balance and how we can treat it. So every 19 minutes, an older adult dies due to a fall, especially the older you get. You know, hip fractures are a really big aspect of that. So falls are very important to avoid at all costs. And just grabbing a walker is not the only solution, and sometimes it's not even the best solution. It can actually make your balance worse. If you're using an assistive device too early, if you don't really need it, maybe just therapy would help and you don't need the walker. So sometimes people wait a long time before they realize that they're really off balance. But if you just feel like you're extra cautious doing things that you used to do all the time, and now you feel like you kind of have to slow down to do them, that could be a sign that your balance is getting off. It's not, don't put it off as just, I'm getting older, I have to slow down. That's not always the case. So, and then if you feel a little bit off balance, just every now and then, or just a little bit of dizzy, just every now and then, that's the start of maybe inner ear weakness and balance problems. So any minor issues, if they're addressed early, then it's a lot earlier to fix. So don't wait too long. Most people, when they see me, they've already been off balance and dizzy for at least 3-4 years. A lot of people have said I've been dizzy for 20 years. That's way too long to seek help. But they don't know about vestibular therapy, so they've been pushed off from doctor to doctor to doctor. So 1 in 3 adults over the age of 65 fall annually. 95% of hip fractures occur at a fall, and 1 in 5 people from that fracture will die within a year. And so of course we're talking about elderly. But I mean, it's a serious thing, falls. You've got to prevent falls. People tell me, well, I asked them, you know, how often do you fall? And they kind of giggle. They're like, I can't count how many times. I'm like, oh, that's not good. You should have been seeing me a lot earlier. And then 90% of falls account for 90% of nursing home admissions. Hopefully they could be prevented. So what causes dizziness and imbalances? There are several things that can. You know, general weakness, if your legs are weak, maybe you've been sick, maybe you have other health conditions. General weakness can cause balance problems and some dizziness. Poor posture can cause balance problems. So when you start having kind of a flex posture, it changes your center of gravity and it can make you kind of get thrown off balance some. So that's something that's really hard to improve. But we can help to prevent it from getting worse. Most dizziness and imbalance comes from inner ear issues. We'll address all that. Very little comes from medication. I think I've had 2 patients in the last 4.5 years that actually had a medication that was causing the dizziness. But doctors say that a lot, but most of the time I haven't found that it's really true. I mean, other things, like if you're anemic, you can get a little dizzy. If you have cardiac problems, you can get dizzy. Most of the time, if people are dizzy, they go to their PCP, they send them to the cardiac person, that all checks out. They send them to a neurologist, that all checks out. They have MRIs, they have CT scans, they can't find anything wrong with them. And they finally go to an ENT, and then the ENT will send them to us. You could have got to me 8 months ago. But you know, it is good to check out the head, scan the head, and check out your cardiac is always a good thing. What does not cause dizziness is aging. It's not a normal aging thing is to be dizzy or off balance. Very little things are normal in aging. Getting gray or white hair, that's normal. Okay, everybody's gonna do it unless you lose your hair. But you know, dizziness and imbalance is not a normal part of aging. There's something that's causing that imbalance, whether it's arthritis or posture or something, but it's not just age. So how do we get a weak inner ear? What does that mean? There's several reasons why you can get a weak inner ear. So the inner ear consists of the hearing part and the balance part. Okay, so here's the cochlea, that's the hearing part. These are the canals, this is the balance part. And then that's your eardrum and the bones that vibrate to make the hearing audible. The weakness in inner ear can happen just from a decline in activity. So we've had some people that said, all right, well, I've been getting dizzy gradually over the past 10 years. Okay, well, what happened 10 years ago? I retired. That's all it said. So when the inner ear starts getting weak, it gets weak very gradual. And so people don't even notice for several years. They can maybe get a little bit dizzy, like when they stand up and they're like, oh, I just stood up too fast. I'm good to go now. And they don't worry about it. I'll just drink some water, right? But that's a sign that your inner ear could be getting weak, and it gets weak very, very gradual just from a lack of inactivity. So our ears stay strong with activity, just like the rest of our body, and our muscles and our bones all stay strong with activity. Inner ears the same way. So in athletes, their function of their ear is like way up here. And then if you're kind of sedentary, then your function is going to be way down here. Hearing loss can cause a weak inner ear. Most of our patients, probably 99% of our patients, have hearing loss. So when you have normal hearing loss, it just means that the nerve is getting weak and the nerve is dying and your hearing starts going down. The same nerve that innervates the hearing part innervates the balance part. It's the same nerve coming out, but it splits. So the balance part will get a remnant of weakness, where the hearing part will get the main weakness. So even though we can't improve the hearing, we can improve the balance part of the inner ear if it's caused from hearing loss. Another way it can get weak is injury. So if you hit your head, even if you don't hit your head, if you have a fall, and say you fall on your shoulder, when you fall on your shoulder, you just get a big jolt, like a whiplash, it can cause weakness to the inner ear. Because when your brain is in your head, it floats in water, right? And so when you have a big jolt, it kind of moves a little bit. It didn't even have to move enough to actually get a concussion. It just moves a little bit with a fall. Those nerves coming out of your brain, the cranial nerves coming out, going into the different parts, including the inner ear, those nerves can just get stretched a little bit, and it can cause injury to the inner ear. So any fall can actually give you a little bit of weakness in the inner ear. And then some people do have a direct blow, and of course that obviously is going to cause some damage there. And then hereditary weakness is just going to be the people that are car sick. If you've always been car sick, you can't ride in Ferris wheels or whatever. That's just kind of your born with the inner ear. It can be worked on. I mean, you can strengthen it still. We had a teenager that had so bad car sickness, he couldn't even go to the movies with his friends. He was 14. So we worked on him, and then he could at least get in the car enough to go to the movies. So that's good. Yes, sir.
What do you call that nerve that connects to your hearing and your canals?
The vestibular nerve is coming out, yeah.
If that nerve is damaged in an injury, would it have the same effect?
Depending on where it's damaged in the nerve.
You want a coup is?
That's a concussion.
Yeah, so if the nerve is damaged more closer to the brain, then you're gonna have central issues. And it's gonna present a little bit different, but it's still vestibular.
Okay,
Yeah, and if it's peripheral, then it's gonna be a little bit easier to fix, but yeah, you need it, yeah. Yes,
So is it common to, like 20 years, 30 years ago, like you get on a roller coaster, any roller coaster anywhere, really, and then about 4 years ago, we went to Universal Studios, my granddaughter, whoa, I made it through, not very well, so is that just common, it just gradually gets worse like that?
yeah, it gradually gets weaker and weaker. And sometimes we can't pinpoint why. Sometimes we can, if you have like an injury, okay, we know why. But sometimes we don't know why. Say you have hearing loss, okay, say you've had 2 major surgeries, so you're down in bed for a week because of a heart surgery, and then another week because of really bad COVID. And then you're retired, and then you have 3 big falls, one of them where you hit your head, and it just builds and builds, and it just gets weaker and weaker and weaker. And then something big will happen, and it can go.
But isn't it fairly common for that to happen to people? I'm only talking riding on a roller coaster.
Yeah, but the roller coaster is an extreme case. I mean, that's very stimulating to your inner ear, and most young people even get a little dizzy on a roller coaster.
Right.
So that's an extreme case. We're talking about inability to even walk across your room, or to stand up, or to get in and out of bed. Inability to do normal daily things, or ride in a car, roller coaster is a little extreme case, yeah. Yeah, I haven't had any of my patients say, I went to a roller coaster now. I have had where they can, go to a grocery shopping now, because inner ears can prevent you from grocery shopping. Because you're looking here, you're looking there, you're looking for the stuff on the top shelf and bottom shelf, and they have trouble with those tasks. You have a really weak inner ear.
To elucidate on what you just said, I worked at Mother Francis in the ortho-neuro. I spent 40 years, 20 of it there. And I don't know if you remember Dr. Stuart Crutchfield, he's a neurosurgeon. I told him one day I couldn't hang IV piggybacks on his patients anymore, because when I tilted my head back to hang the IV bag,
Yeah,
the room started spinning and I was gonna fall in bed with his patients.
Yeah.
And this was before they really knew about the bony fragments in the semicircular canal. So he sent me, I can't remember the doctor's name, to do the positional. And if I had gone to a tent meeting and somebody had slapped me and said, God healed you, I would have said, oh, it's a miracle.
Yeah.
One maneuver
Yeah.
cleared the whole bony fragments.
Yeah.
What
Yeah. So you had BPPV,
I did,
yeah, which is
exactly.
a different diagnosis. We'll talk about that too. Yeah,
But
yeah.
it was
Those,
so new at that time.
Yeah,
that-
yeah.
Yeah,
yeah, those are fun patients. Those are fun to do.
it was a
because
miracle.
you
yeah.
can hit it with one treatment and they're like, oh my gosh, I'm like, yeah, I know, it's great, isn't it? Everybody wants a quick fix, so that'd be
Are
great.
those the crystals that they talk
Mhm.
about in here?
Right, yeah,
Oh.
Yeah.
But they
Yeah.
didn't hit you or anything.
yeah.
Did they hit you or what they? did?
No, there's a maneuver that you get that fragment that it's a little hair fiber that breaks off in your semicircular canal and circulates and throws your whole balance off because the brain's getting fake signals.
Yeah,
And
yeah,
they
we'll talk about that
position
in a
you to
minute.
pass that bony little fragment through
Yeah.
the semicircular canal, and once it's gone, you're
Well, how'd they get it out?
What did they
A head
do?
maneuver.
It just
So there's certain head maneuvers that you do,
You
there's
swallow
like,
it.
there's like a bunch of them that we do, yeah, we'll talk about that in a minute.
Oh.
We're gonna charge you for that, yeah, well, it's better to do that in a clinic. Okay, so this is where we kind of come to that is. When people talk about vertigo, when people talk about dizziness, that's a really big umbrella. What does that mean? Vertigo, people throw around the name vertigo all the time, when there's true vertigo, and then there's stuff people just call vertigo.
There's
So-
a movie.
Vertigo is an actual spinning sensation, like the room is spinning around you, or you feel like maybe you're spinning. That's true vertigo. Just because you're dizzy does not mean you have vertigo. So that would include BPPV, like she was talking about. BPPV, benign paroxysmal positional vertigo. Yeah, he's looking at me like, what's BPPV? Yeah. We'll talk about that in a minute. So, you know, when I evaluate someone that says they're dizzy or off balance, this is what we kind of go over. You know, are you spinning? The lightheadedness is just like a woozy, like if you stand up too fast, you're just like, what, oh, okay, I'm good. It can just last seconds. And then wobbly, so not everybody that has a weak inner ear is actually dizzy, some of them are just off balance. And when you're wobbly, you know, maybe a lot of times people say they feel like they're drunk, or they feel like other people think that they're drunk. When they're walking, they kind of veer maybe to one side or veer back and forth. They can't walk a straight line. They run into walls or run into door frames. So you don't have to be one or the other. I mean, you have to be one or the other. Sometimes people are both. It just depends. Behavioral dizziness has been a big one for us. I'm really surprised about how much we deal with behavioral dizziness. A lot of anxiety, and a lot of fear comes with being dizzy, because nobody likes to be dizzy, and it's scary to be dizzy, especially if you don't understand why. And then people fall, and then they get a fear of falling. But if you have so much anxiety about moving around, about being dizzy, you can actually make your own balance worse. You can make the dizziness worse. And so we have safety harnesses. There'll be a picture up there and it's on your brochure. We have safety harnesses in the clinic, and we strap everybody in a safety harness, no matter how old you are. And we strap, there's a rope, like rock climbing stuff, there's rope and a strap to a track in the ceiling. And so you cannot fall during therapy. For one, that allows us to work on the behavioral dizziness. They start to trust the harness, and they get to where they're more willing to do the things that we're asking them to do, which are challenging. And then that really helps them to improve better, because we can challenge them more than normal PT would. And then motion sickness is usually nausea, vomiting. Lots of people have that and play with the inner ear. There's a lot of different things. Okay, so hypofunction of the inner ear, what does that look like? So if you have difficulty bending over and coming back up, and you have to hold on to something, or you get a little bit lightheaded, that can be inner ear weakness. Looking up, people have trouble doing that. They feel like they're gonna fall backwards. Or just turning. A lot of times, like, okay, I just kind of turn real slow. That's usually inner ear weakness. Unsteady, not confidence in crowds. So there's a big visual aspect to the inner ear as well. The visual field, the inner ears have to communicate a lot. So when you get into crowds, it can really be very stimulating visually. Or riding in a car, traffic, anything like that can really hinder it as well. Feeling like you need to touch something for stability. So if you furniture walk, that means you have off balance. Okay, if you use any kind of assistive device, you're off balance. If you just feel like you just need to touch something for your security, then you're off balance somewhere. You may not realize you're off balance, but that's your body's way of saying, hey, I'm unsteady. You automatically start touching without even really thinking about it, because some people don't even realize. They're like, no, I don't use an assistive device. I'm like, well, do you touch stuff? I touch my couch and I touch my counter. I'm like, that means you're off balance. They're like, oh, yeah. Difficulty reading and scrolling on phones. So watching action movies, anything like that can be a weak inner ear, because the visual system is so intertwined with it. So scrolling, some people have computer screens they're working at, and they're having to look back and forth on two screens, then down the keyboard and back and forth, and it makes them sick. So that's inner ear weakness, visual stuff going on. And then of course, motion sickness in a car or a movie theater. So all of that can be a weak inner ear. There's two different types of weak inner ear though. Kind of like I talked about earlier, there's peripheral, which means just the semicircle canals are weak, or you can have central, which means more like the brain is misinterpreting the communication between the ears and the eyes. That's a little bit harder to fix, and it's different, presents a little bit different. So sometimes stroke people will have a central weakness, or they're a little bit dizzy because it's more brain related. TBI, brain injuries, concussions, things like that can be more of a central. Some of the symptoms are the same, but they'll present a little bit different. The other big diagnosis that we see a lot that is completely different is BPPV. So BPPV is where, so we all have tiny little calcium deposits in our inner ear. They're called otoliths, and they're 100 times smaller than a grain of sand, and we have millions of them. And they're stuck together with little gooey substance, and they serve a very important part for our balance. Sometimes a chunk of them can come off, and it'll get inside one of the semicircular canals. When that happens, the purpose of the canal is to detect motion. So when you move, the canal is telling your body, hey, I'm moving, everybody kind of go with, right, stabilize. So when there's something floating in the canal that's not supposed to be in there, it reads it as motion, kind of like a stick floating on a pond, the ripples. It reads it as a motion that's not occurring. The inner ear will send signals to your eyes to stabilize. So they start moving, it's called nystagmus. They start moving to a motion that's not even occurring, and it makes you feel like the room is spinning. That is the only symptom that BPPV causes. The room is spinning. Usually when you lay down, or when you roll left or right, or sometimes when you look up, if you're extremely up and you kind of tilt a little bit, you can get it just from looking up. But most of the time it's from people laying down. A lot of times it's a very easy fix, depending on where it's at and depending on how long it's been. But a lot of times we do different head maneuvers. We can get the crystals out and then you're good. So the head maneuvers, like say the crystals are here, we lay it down, they kind of float, we move your head this way, move your head that way, move your head that way, and then go out. So it can be just like that. Sometimes it's harder. Sometimes people try to fix it on their own and it makes it harder for us. That's why we don't recommend people Google anything, because most of it's wrong. Please don't Google the Epton maneuver and try to do it on yourself. Yes, I know, you will make yourself sick, you'll make it worse for me trying to fix it, and it just most of the time it doesn't work.
Question.
Yeah.
Benign postural P vertigo, what is the second P?
Paroxysmal,
Paroxysmal.
Paroxysmal.
yeah, paroxysmal, yeah. Just Google BPV, it'll give you, yeah, I just gonna BPV. So that's what the problem with that is, though, that people are just like, well, I'm spinning when I lay down to my right, so I just quit laying on my right. Okay, well, how long has that been going on? Oh, about 10 years. I'm like, oh my goodness. So in the meantime, those crystals are in your inner ear canal and it's desensitizing it because it's overstimulating the inner ear canal. And now your inner ear canal is weak and now you have all the other symptoms because of this one. So if we can get it out as soon as we can, you can go about your life, no problems, because this will not cause that unless it's been there too long. So we urge people, as soon as you feel that spinning or even think you feel it, then, you know, come, let us get it out so that you don't have to go through more therapy, even though we don't mind seeing you. You probably don't want to do it if you don't have to. So the vestibular therapy focuses on the function and the communication between the inner ear and the visual system. These two are so intertwined that when the inner ear starts getting weak, if you wait too long, now the visual is getting weak too. And then before you know it, they're both weak, you're really dizzy pretty constantly, and it's pretty miserable. So that's why it's important, as soon as you feel any kind of dizziness, to go ahead and get it checked out and let's get it fixed. The longer you wait, the harder it is. Because your eye, I mean, it can be just your eyes, maybe it's not your inner ear, or maybe it's your inner ear and not your eyes. But we have a test that can test that out, and when we can figure out which one it is, then that's how we direct therapy. So a lot of therapy is, it looks pretty silly. There's a lot of head movements, up and down, left and right, diagonals and Z's and all this stuff, and then you include the visual system with some thumb stuff. You're focusing on your thumb, or you're looking somewhere, or maybe just your eyes are moving, and your head's not moving. There's a lots of different combinations, and depending on what your symptoms are, what's stimulating you, and how to get them to cooperate together, because these two have to communicate together, or you're always going to be off and dizzy. So, visual is a big part of it. So this is an example of our testing. So we have what's called a CDP machine. It's a computerized postography machine. I have couple of brochures over here about it, so was really interested in it. So it's like, I'm gonna put it up there, so it's like a dome. So we get you in a dome and you're still strapped up with the harnesses, but we get you in this dome, it's almost like a little mini IMAX. You're completely surrounded by the environment. And it tests you in different ways so that we can see the 3 systems that work in your body to maintain your balance. Is somatosensory, which is touch, which is why we start using walkers and canes. And so, we have somatosensory, we have vestibular, that's your inner ear, and then we have the visual system. And then this one is visual preference, so we all rely on our visual system the most. And then these 2 are like secondary. So this one shows us how much we're relying on the 3 as we should. If it's excessive, then we're relying too much on visual. If we rely too much on visual, the visual effects can be oversensitive and it can make us like nauseated and stuff in big crowds and stuff like that. But if we don't rely on it enough, then our balance is gonna be bad. So it tests those 3 systems individually, and then we can see exactly which ones are low. Like for this person, the inner ear was not kicking in at all. And the visual was low. They went through 5 weeks therapy, then the inner ear kicked in, still low, but it kicked in. And then another 5 weeks of therapy, then it went above normal and we're good and good. We want green, everybody wants green. And then it showed how overall equilibrium went up with the therapy. So this really helps us to focus on therapy on if we're focusing on inner ear or visual or both. The test is hard, but it gets really good results. So there's a picture of the safety harness. And so this is the track, that's the track in the ceiling, and it's like 1,000-pound grade, so it'll hold you. Some people aren't sure about it, so they sit there, they kind of sit in the harness and they're sitting there kind of just swinging. They're like, yeah, okay, all right, this will hold me. I'm like, yeah, it will. But you can't glide across it. We tried, it stops. But it really helps, because especially those people that are very fearful are falling and don't really trust us because they don't want to fall. It really helps a lot. Besides inner ear, the other things that can benefit from just very detailed balance training is any neurological diagnosis, stroke, concussion, Parkinson's, MS, ALS. Because these impairments cause your mobility to slow down a lot or to even stop, an inner ear aspect is usually involved. So we address that, plus the normal balance, musculoskeletal balance issues that we would do with this diagnosis anyways. We get really good results to improve them or at least help maintain. We do a maintenance program. So we see Parkinson's for years and years and years sometimes. We can do maintenance program on really anybody that has the right insurance. Medicare will pay for a maintenance program. So we can see Parkinson's. I think there's some people we've seen for 5 years.
Like weekly or?
It depends on their need. If they need twice a week, so we start out twice a week until they improve, and then when they plateau in their progress, then we taper them down to once a week. We really coach them on how to maintain it at home. If they maintain it well, then we might go down to every other week. If they start declining, we bump them back up and like, all right, that's what you need. And we just stay with that. Unless something happens and they have a decline for another reason, then we'll bump them back up to twice a week to gain it again. Yeah.
Do you see head injury patients as well?
Yeah. Yes, yeah, TBIs, concussions. Yeah, they're a little different, but yeah, definitely a big vestibular aspect to that, but much more central. So not nearly as easy to progress. The thing about vestibular is that your symptoms come and go because this is neurological. This is an adaptation type of therapy. So you're gonna have good days and bad days. And that's why people wait so long to get help, because they have a couple of bad days and then they have some good days. Like, oh, good, forget it. But then they have bad days again. And so it really needs to be addressed when you're having the good days and bad days.
If you've got 2 ears. So they work together for balance, or do they work independently?
Yes and yes. They work together, but also independently. So you have 3 different canals in each. So when you move, this side is being excitatory, this side being inhibitory, and so they both work. But they work a little bit differently depending on what your movement is.
So if you lose half of them, the other half can still function? And can
Yes,
it be
yes,
improved with
yeah.
therapy?
Yeah, if you lose one ear completely, like we've had people that have had, so schwannomas, if you have like a tumor in your inner ear and you have to have the whole inner ear taken out. There are people still help because you have the other inner ear. And if we can make that as strong as possible, then it can compensate for this one not even being there. It may not be perfect, it depends on the person, but we can strengthen it and it can definitely help your balance. Yes, ma'am.
I'm very optimistic and hopeful about what you're talking about, because my husband Stephen here has been having instability issues, and he has had both personal trainers and physical therapists, and he is not a sedentary person. We go to the gym and he does cardio and strength training. None of the people that he has worked with has talked about vestibular
Right,
connection.
yeah.
Why is,
That's
I mean, that's
they
crazy.
just don't know enough about it. That's the missing link. We have people that have had strokes and they've gone through a ton of therapy. And they're like, I'm still off balance. Can you help? I'm like, yeah, maybe, let's try it. And then, yeah, that was the missing link. No one addressed the inner ear. Yeah, because I mean, those 3 systems, no matter what your problem is, the 3 systems all work in everybody's body. That's the 3 systems. So if you don't address all 3 of those systems in your balance, you're not gonna fully improve your balance. You're gonna make it better, but you're not gonna fully improve it until you address those 3 systems. And somatosensory includes musculoskeletal. So strengthening, just normal strengthening and stuff like that is included in the somatosensory system.
So do you have to have a referral from a doctor to get there?
Right, yeah, any doctor, yeah, any doctor.
You'll bite.
Okay,
That's one of them. So someone said, I live in Florida. Over the last 10+ years, I have been to lots of doctors regarding the dizziness. What kind of doctor do I need to see in order to get a diagnosis and therapy? So that's any doctor or?
any doctor that's willing to send you to vestibular therapy. Yeah, and Florida has physicals because physicals started in Florida. Yeah, so there should be some good. Now, not all physicals focus on vestibular. The franchise of physical can be normal outpatient, but every physical has the chance of the same education that we have. So there should be some therapists there that are focusing on vestibular therapy. Just make sure that you don't have to have a diagnosis per se. Any doctor can refer to vestibular therapy for dizziness. That's all we need. We can differentiate enough to know if this is in our ear or if it's other stuff going on. And if it's not working like we think it should, then we'll refer back out to like an ENT. Yeah, if they do want to start with a doctor that understands, then I would start with the ENT.
Someone else said, I am lightheaded / disoriented 24/7. I've seen numerous medics. Any ideas?
Come to therapy. Yeah, so I mean, that's what happens. People get lightheaded and dizzy and off balance every once in a while, good days and bad days. So there's a lot that goes into why someone might have sporadic bad days. Weather, storms, moon cycles, anything that changes the barometric pressure will affect how you feel that day. If you're off balance a little bit, you're gonna feel the barometric pressure effects a lot more than if you're not. So, you know, the moon cycle, and people are like, is that real? Well, yeah, it's real. The moon cycles affect the tide in the ocean, right? Well, your inner ear is fluid. It's all fluid. So the barometric pressure affects you too. It affects people in nursing home. It affects people with autism. I mean, it affects all of us. But for us that are healthy, we don't feel it because we don't have anything going on. If we're unhealthy, we have an impairment, we're going to feel the barometric pressure worst. So that's why a lot of times people are like, well, you know, I feel bad on stormy days, but they dismiss it. But that's a sign that your inner ear is weak. So people feel the symptoms just every once in a while. And then slowly it's going to get worse and worse and worse. And then sooner or later, 5-10 years later, just like that person on Zoom, they're like that 24/7, because now, probably if we did the CDP on them, it'd be 0 and 0. Neither one of them are kicking in, they're solely depending on somatosensory. And so that person, I'm sure, is using an assistive device, because that's all they got. So, you know, assistive devices are good when they're really needed. The doctors don't know anything else to tell people. If they're off balance, they're like, well, use a walker. Okay, but if you use a walker prematurely and you're not working out these two systems, now you're making this system do too much, and these are gonna get weaker. Because now you're not even using them, you're relying too much on the somatosensory system, and the walker's actually gonna make you weaker if you don't need it. Obviously, there's sometimes you do. Yes.
A friend that we couldn't come today, she was saying that she gets dizzy, but she has sinus, allergy
Mhm.
issues. So is that something therapy can help, or is that more of an ENT issue?
So it depends on how chronic the sinus and allergies are. If she's only just a little bit dizzy when she has sinuses and allergies, and all the other times she's perfectly fine, you know, this is gonna have an effect. Anything here is gonna have an effect on the inner ear. That could be a sign of weakness. If we got this stronger, maybe she wouldn't feel the effects of the sinuses and allergies as much. It just depends on what else is going on. Sometimes people don't realize they have a lot more going on than what they know until I start asking questions, and they're like, yeah, I do. It does happen, you know. A lot of them is if they go grocery shopping, they have to have a buggy. You have to. You can't grocery shop without the buggy. That's a sign that you probably have some inner ear stuff going on. Yeah.
I want to ask, how does tinnitus affect balance and dizziness?
So tinnitus usually comes with hearing loss. It's about nerve damage from the hearing part. The tinnitus itself doesn't really affect the balance, except for the fact that it's a sign of hearing loss, and the hearing loss affects the balance. A lot of times when you have a weak inner ear, people feel like pressure here. You can feel like a fullness. And sometimes the tinnitus will be louder with a weak inner ear. So we can't get rid of the tinnitus, but a lot of times we will make it quiet it down a little bit, which is very helpful to some people who have it really loud.
And then someone else asked, what are things I can do at home to help with any of this if I'm not able to get to physical and time?
Yeah. So it depends on where you are. That's a hard question, especially over Zoom where I can't see. If you're relatively healthy and you exercise and you want to stay active and you don't have any symptoms in your exercise routine, you should be adding head movements. Okay, so if you walk and take a walk down the street, when you're walking, it's gonna look silly maybe, but when you do, you just kind of look over here and you just kind of look over there and you just kind of look over there, you know, and then you may, when you go back, you may look up and down, just nice and easy, up and down. You might look over there, you might look over down there. Just add some of those head movements in the normal routine. If you do static balance test. So people practice standing on one leg or feet together, you know, if you're standing with feet together to practice, just nice and easy, move your head, you can hold it. Because the longer you hold it, the harder it is. I'm stimulating my inner ear canals here, and then I'm stimulating some here. This is one of our exercises we give people. And you hold it over here, and then you hold it over here. So, or you can just go up and down, nice and easy. This stimulates the inner ear canal and visual system too, because your eyes have to follow you. If you put that in your normal routine, normal exercise routine, it'll help maintain what you have. If you're off balance and you're a little dizzy, same thing, but careful, don't fall. Okay, when we're strengthening all these canals, we have to stimulate them just a little. If we stimulate them too much, for one, you might fall. For two, your systems cannot adapt to it. So if I go and start lifting weights, I'm not gonna grab a 100-pound dumbbell and start doing bicep curls, because I'm gonna tear my bicep, right? Little bit by little, I'm gonna grab a 5-pound, a 10-pound first. So little bit by little bit, you stimulate the systems, and then gradually it'll adapt, and then you can make it harder and harder. So if you cannot get to a clinic, for one, I suggest at least come to a clinic once, let us test you, let us make sure it's in your ear, let us see which system it is, so we can properly give you the right home exercise program. And then if you need to do it at home, that's fine, we'll help you. You can come back 5 weeks later, retest again to make sure you're being successful. Sometimes people trying to do it at home cannot stimulate themselves enough to really succeed well. Because you need more stimulation than what you can do at home. Because we have the harness systems and the safety systems and a ton of balance toys, we can stimulate you. And it needs that little bit extra stimulation at least 2 to 3 times a week. So we recommend people come to therapy if at all possible, even if it's once a week or every other week. There's a lot of education. I just barely touched the coat of everything that goes on with this. It's very complicated. And so we have people that just come for 2 or 3 visits to get all the education so that when they go home and do the home exercise program that we give them, they know what they're doing and they're much more successful at it. And then they come back and get retested and make sure, and then we adapt it, because this is very, very dynamic. Every day we do something different, because every day people's symptoms are different. We have to meet you where you're at those days on that symptom. You might be really stimulated that day, we can't do as much. You might have a really good day, we can do more. So it's very dynamic. It's not like, here, do these exercises and you're good. Some doctors will give them some exercises and they're like, these didn't work. I'm like, yeah, well, I can tell you why. So I do recommend people come in so that they can get a good idea, because if you do too much, we don't want to fall. But anything, what you don't want to do is, if you're having balance and dizzy, or especially dizziness problems, you don't want to avoid the activities that are making you dizzy. Don't avoid them altogether, because that's going to make the inner ear weaker. If you do an activity, it makes you just a little bit dizzy and you're still good, you still maintain your balance, you're just a little dizzy, do that activity, because that's exercising it. Now, if it makes you really, really dizzy, don't do it. But if just a little bit dizzy, that's your body telling you, hey, this is hard to do. You know, I have weakness. And then you know to do that activity. So, I mean, it's so complicated. I can't really tell that one person what to do. If they can just get to a clinic one time, we can do the testing. I can look to see, and then we can give them home exercise program. And we really work with it, because we have people that drive 2 hours sometimes to get to us. And then they maybe they never come back, but at least they know what's going on, and we can give them a little bit of help.
Leah, I wanted to share my own experience. For some reason, I think it's a God-given thing. There's 11 years difference between us, and I just hit another decade milestone, and I have no one in the world. I'm an immigrant, and it's very important for me to stay independent. So the first thing I became aware of, I want to be able to drive. And I think it was a neighbor, it was Penny. She was having trouble turning her head to see if she could change lanes. So I just automatically started doing this and these rolls. And then I also found that, being who I am, I have this type of kyphosis in my back, and I tend to hold tension up here, not in my lower back. So I've started doing these head rolls, and I found that it really helps me to relax and ease things. And the last thing that happened to me is I developed glaucoma. So my husband times me for the 2 minutes that my head is back, and I put in the drops, and then I'm holding onto the counter and rolling, and then I put my arms to exercise my triceps.
Yeah.
So this makes a lot of sense.
Yeah. Oh, good. Well, it makes sense. Yeah, it really does make sense once you kind of start experiencing what we're doing. Because then we start testing people, and they're like, well, why'd that make me dizzy? And we explain it to them, and it really does make sense. Yes, sir.
What if, in the exercise class that I attend with Courage Health, we do various things, some that you've already mentioned, and I'm going to ask if we can suggest that someone be added back in. But in order to, they had us standing heel to toe without, well, in order for me to get to that point, which I have to admit I quit doing, so I had to start all over again. Is some told me to focus on one thing. And that would help me keep my balance.
Mhm.
Well, it did. If I look around,
Mhm.
I may not, so,
Yeah.
and I do have vertigo about every 4 or 5 years. So, you know, is focusing first so that you get fine, once you get that done, then you can begin to add some of the other.
Yeah. Yeah, so when you're focusing on something, your visual is stable.
It's a focal point, like in yoga.
Yeah, when you start moving it around, you're challenging your visual system. You're already challenging your somatosensory system because you're in tandem. So you're challenging that. If you keep your head still, I'm doing it, as y'all can tell. All right, if you keep your head still, then you're not challenging the inner ear at all. And as long as you're focusing on something, you're not challenging the visual system. It's helping you to stay focused. When I just move my eyes, now I'm challenging my visual system. My inner ear's still not challenged, but my visual system is challenged. So now I have two. Then when I start moving my head, then it really gets kind of cattywampus because now I'm doing both. So what if you close your eyes? Yeah. So if you close your eyes, this is out, right? This is already challenged. And now, even if you don't move your head with your eyes closed, your inner ear has to work harder. So if your inner ear is weak, just stand there with your eyes closed and practice that. And it makes your inner ear work harder.
But it's okay to start small.
Oh, absolutely. You should start small.
As you can.
Yeah. So if
And I
you're,
was told when my doctor told me I had vertigo, and it was a neurologist that told me.
Mhm.
And he seems to have been the only one who could find what problems I was having. The others tried, but he didn't. He told me to just tilt my head this way and then this way. I'm afraid to tilt my head this way, because when I tilt my head this way every 5 years, that's when the vertigo comes up.
is it
But-
spinning? Is it BPBV? Is it spinning? Like, is it BPBV spinning?
Think so, because it
Okay.
doesn't, it's just that. I don't know, maybe it feels like I'm floating or something, I have to hold
Okay.
on and sit down, and I normally have to. I'm down on the bed from 1 to 5 hours depending on sleeping.
Okay.
Okay, but like the last time it happened. It's about a year ago now, I was in bed when it happened. I started to sit up and I thought, whoo, no, we're not gonna do that, and then the room spin, but then it stopped. And I lay there and I thought, I've got to get up because I'm by myself, I've got to do. So I had a shower chair that when I had knee surgery, I had it was over there. So Count Lowe reached it over and I was able to get up and function.
Mhm.
And it went away a lot faster than it had before, but I am on medication for other things up here. So I think that's what helped to make it go away better.
Okay.
That's my diagnosing myself.
Yeah, I mean, it depends why you have vertigo. Like, I mean, it's not always BPPV. Sometimes it's inner ear stuff. Like if you have inflammation, if you have neuritis, your nerve is inflamed, it can cause vertigo. That's a good point about medications though. So a lot of times doctors, especially ER doctors, they love methylazine. They just love it. And it doesn't work for one. And the other thing is that it makes the inner ear weaker. So you're gonna give someone methylazine for dizziness, but it's an antihistamine.
It's not what I'm thinking.
But that's the most common one I see. It decreases the inner ear function. That's why it stops your dizziness, but then it just makes it weaker, and that's what we're trying to do. We're trying to strengthen it up. Other medications that can weaken your inner ear is any anxiety medication, Valium, any anxiety medication weakens your inner ear.
I just want to add, in my personal experience, my big takeaway from having BPPV is it is so easy to diagnose and so easy to cure in a split second. I would suggest everybody go and be evaluated, because if that's your problem, you can get rid of it immediately.
Yeah, most of the time, not all the time. There are hard cases.
Well, there are, and I've had
Yeah.
to repeat it too,
Yeah.
but I mean,
Yeah.
that is the easiest fix in all the medicine I've ever been exposed to.
Yeah. Yeah, it's
I've
great.
got a couple of observations.
Okay.
And the first one is, just like this lady,
when she said, I kinda got like this, when I go and talk to the doctor, and he says, what's going on, I get dizzy. Is the room spinning? No, it's that trying to explain to somebody
Right.
what's going on, when I can't figure it out myself, I don't know.
Yeah,
The other thing is, that in that list of diagnostics that you had up here. If it's this kind, this happens, if it's this kind, this happens. I have never had a doctor ask me that before.
the types of dizziness?
Yeah.
They're not, yeah,
in that fashion, I
yeah,
mean,
they don't
that to
know.
me, I nailed it down to at least one or two things.
Yeah, yeah.
From purpose of me, I don't have vertigo, I don't have it.
Right.
I know what that is,
Yeah,
that's interesting.
Yeah.
I heard
So-
that here, but I didn't hear it from any doctors.
yeah, so I've developed ways to explain it in, just from experience and having so many patients do it. And so, sometimes the room goes. Just things move, but they're not spinning, but they're just kind of fluttering, like going back and forth. Sometimes you're just lightheaded, just like a whoa, you have a whoa motion, right? Sometimes the room goes. We call that the whoosh. The room could go whoosh, but it doesn't spin. But it half turns. But sometimes people are like, oh, it's spinning. I'm like, is it? Is it a 360? Cause that's a spin. If it's a whoosh, that's not a spin, it's a whoosh. And so that's not BPPV. People are like, oh yeah, it's more like a whoosh. I'm like, okay, it's not BPPV then. If you have BPPV, you know it, cause it just literally, the room is like a merry-go-round, helicopter blade type stuff. And then some people just feel like they're drunk, they just kind of like. Theater, they're bumping into their friend they're walking with and they bump into them. They can't walk in a straight line. So yeah, there's a lot of different ways to describe the dizziness. And doctors just like to do vertigo and that's it.
I've got 2 more questions on Zoom and we're kind of almost wrapping up, so I'm gonna hit these and then we'll kind of break some of that. So someone said, my mother just had a stroke and one of the main symptoms of the stroke brought on major dizziness and nausea. It's gotten better as time has gone on and she is in physical therapy. However, it still happens. Could this still be an inner ear thing or would it be directly related to the stroke?
It could be either, depending on where the stroke is. Also, depending on how active she was prior to the stroke, if you're a very active person and then suddenly, boom, you're down, then your inner ear can go, it gets lazy so fast. So it could be completely inner ear, it could be completely stroke, or it could be a combination of both.
And then someone asked, how can I schedule an appointment with you? And I know you mentioned that it's better to come in person to get evaluated first, but do you ever do anything virtually to get people started?
I've thought about it, but I have not figured out a way to safely test someone's balance virtually. I do not want you falling because I'm trying to see if you can walk tandem. Yeah, and the harness, we really rely on the harness systems. So, I mean, I don't mind, I'm sorry,
How do I in-person people or someone that has like a vestibular therapy, physical near them, how do they get started? Just that doctor's referral?
yeah, doctor's referral. Yep,
What do you have them refer?
as long as it says dizziness, I'm good. I don't need a diagnosis, just dizziness,
Say physical?
or it could be off balance. Oh, well, they're gonna send it to
How about
physical.
postural hypotension? Would you address that? Because that came from a neurologist who was diagnosed with that. That can be a cause of dizziness because.
It can be, but make sure when they test you for that, because that's a very, very simple test. You can even do it yourself. When they test you for that, the rule is 30 points. Your blood pressure has to drop 30 points to be true orthostatic hypotension. If it's not 30 points and it just drops a little bit, you cannot blame dizziness on that. I had a patient just a couple weeks ago that said they're diagnosed with that, and I was like, well, how much did it drop? They're like, oh, I don't know, about 10 points. I'm like, that's not orthostatic hypotension. The neurologist throw it on there because they don't know what else to say.
Where do walkers and canes fit in all this?
If you need it, then you're gonna, use it. I mean, some people were able to get off of walkers and canes, some people, and some people we can't because of other medical issues. Pain, arthritis in knees is a big one, back pain and back arthritis. I mean, it's a big one that puts people on assistive devices. It just depends on your safety level. It depends on how you react to the therapy, if we can make you safe enough. Sometimes it gets to where people can at least go without an assistive device at home. And then when they're in a crowded place, maybe they do have to use it. It's really, really variable. We have gotten people out of wheelchairs before into walkers, and that's a pretty big step.
Again.
So it just depends.
I've had enough issues with my life. I've had a couple of canes, a couple of times. I've had walkers a couple of times. And my doctor just said, you need a walker. And I'm resisting that because the kind of hits that I get, when I get one of these dizzy spells, I get it, walker's not gonna help me at all. I'm gonna go right through the walker.
Yeah.
And so, I don't know, I don't think that kind of thing is a value to me, but because I don't think it's a value, what am I trying to say?
I heard you say it's occasional, you don't have to use it in each environment, it can depend on the day for the barometric pressure,
sure.
it can depend
Yeah.
on, are you in a crowd, is it
Yeah.
voice, is it sound?
Yeah, there's a lot going into if you need help with your balance or not, depending on how you're feeling that day, what environment are you going into? Do you need a cane? Do you need a walker? I mean, there's a lot more that goes into assistive device advice than what doctors know. Instead of telling people to use a walker, I wish they'd just send people to therapy and let the therapist advise them on that. Because the doctors just, they don't know what else to say.
Where are you guys located?
And Grande at ENT Associates, yeah, inside of ENT Associates.
And Leah's card and the pamphlet, that has all the information about, her therapy is on that desk. So if you haven't grabbed it, make sure, and you have more questions or you want to talk to Leah, make sure you grab it on your way out, okay?
Is there an email? Is there an email on my phone?
Yes.
Okay.
And I will also have those resources available for all you guys on Zoom. We will send it out, okay?
Oh, okay. Yeah, I mean, I can give out my email address if anybody wants to ask any more questions.
Yeah, of course. Can you put it in the chat? Or
Yeah.
can Wendy put it in the chat?
Yeah,
Let's
she can
see.
put it in the chat.
We're gonna put Leah's email in the chat message. Okay,
Yeah.
there you go. Okay, guys, thank you so much, and thank you to Leah. That was awesome. Amazing presentation.
I'm serious. Who we call it?
Oh, like in general, the education seminars? Oh, that's me. I set all of them up with Courage Health. So, yeah, you can, my name's Kayla. That's awesome. Yay, awesome, that's awesome. Okay, and then we also have all of the past KourageConnects, which is all of our education on YouTube. So, if you guys are interested in that, they're on our YouTube. Okay, and then that's it. So thank you guys for coming, and we'll see you next month, okay? Thank you guys. We'll see you next month.